All right. Hello, hello. Good afternoon, good morning, or good evening if you're tuning in from overseas. Welcome to another edition of our NSWOCC and our Wound Ostomy and Continence Institute Continuing Education webinar series. Today, we're so happy to be featuring this presentation on optimizing pressure injury prevention, identification, and management across the care continuum. And we have a fantastic guest speaker with us today. But before I introduce Emily, I want to go through a couple little housekeeping items. First things first, I want to get everyone to click on the chat button in your Zoom toolbar. If you click on that chat, let us know where you're tuning in from across the country or internationally, maybe what your role is with wound care as well. My name's Troy, and I'm the Chief Operating Officer of Nurses Specialized in Wound, Ostomy, and Continence Canada, and I'm happy to be moderating today's session. It's made possible today with the help and support from Solventum, so thank you so much for making that possible for us today. We're also partnered today with the Canadian Pressure Injury Advisory Panel, who are helping support pressure injury prevention and management across Canada. So thank you again for their mission vision that we hope to take some learnings from today and pass it on to all of you, of course, in doing your own roles across Canada and globally. We're going to be doing a Q&A session today. So if you have questions throughout the duration of the presentation, if you don't mind clicking on the Q&A button rather than the chat button and put them in there, that'll make sure we can organize them as best as possible and get to as many as we can at the very end. We're also recording today's session, so it'll be available to watch after the fact. You know, some people may be at work today, so if you have to head out a little bit early, not a problem. You'll be able to watch this afterwards on our NSWOCC.ca website. There's also going to be certificates of attendance issued, and we encourage you after this webinar, you're going to get a little pop-up in your browser to complete a evaluation form. So please do take a second to do that. We'll also send that in a post-webinar email to you. So without further ado, it's my pleasure to introduce today's presenter, Emily. Emily Greenstein is a certified nurse practitioner at Essentia Health in Fargo, North Dakota, and holds an advanced credentials, including a CWON advanced practice and FACCWS. She achieved her Bachelor of Science in Nursing from Jamestown College and her Master of Science in Nursing from Maryville University. She's also certified as an adult gerontology nurse practitioner through the American Academy of Nurse Practitioners. Emily's actively involved in advancing wound care through both clinical practice and professional leadership. She's the past president of the North Central Region of Wound Ostomy and Continence Nursing Society and currently serves as chair-elect of the American College of Clinical Wound Specialists. She has also contributed as an expert reviewer for the WOCN Society and the Journal of Wound Ostomy and Continence Nursing, and is a blogger for Wound Source. Her work is focused on advancing evidence-based wound care and improving patient outcomes across care settings. So without further ado, I'll pass it over to you, Emily, and thanks for being with us today.
All right, great. Thanks, Troy, for the introduction. So like you said, my name's Emily. I'm in Fargo, North Dakota, and I'm going to talk to you today about optimizing pressure injury prevention. So a couple of back or housekeeping things. First of all, this is just sponsored by Solventum, and I am a paid consultant for them. These are my disclosures. So our objectives for this presentation, we are going to look at the patient journey to identify risk points and implement evidence-based prevention strategies for our patients that are at risk for the development of pressure injuries. We're going to review clinical decision-making frameworks for selecting effective pressure injury treatments, and this will include advanced dressing selection as well as some negative pressure wound therapy modalities. I do have a little bit of some exciting new technology that has just come out in the negative pressure wound therapy world. And then we're going to analyze some real world cases and see how we can translate that into everyday clinical practice. And then, of course, we'll have that question and answer session at the end. So first of all, before we start, we need to define what a pressure injury is. Most of us have seen pressure injuries. We're very familiar with them, but we maybe don't know the exact pathophysiology behind it, or we might not know the clinical or the scholar terminology, what it means. So what is a pressure injury? A pressure injury is a localized skin damage that's occurring over a bony prominence or over an area that has been exposed to prolonged pressure, and it's usually combining with shear also. This sustained pressure can reduce blood flow, leading to ischemia and subsequent tissue death. So what happens because of that pressure and shearing, what it's doing is it's closing down those capillaries, which is preventing blood flow to the skin. So when we talk about assessment, a couple of key categories that we're going to want to look for when we're looking at our patient is looking at the temperature of the skin, making sure we're documenting that. Is there an increased temperature there? There is a lot of studies out there right now showing that the temperature increase can be a very early sign of a stage 1 pressure injury. There are technologies on the market right now, as in thermal imaging, which can show changes or early changes in patients for identifying those at a higher risk, which can lead to implementing some different strategies early to hopefully prevent the development of a pressure injury. We want to be sure to note on our assessment skin color. We want to check for blanchability, but we also want to be very cognizant or note that there are different presentations depending on different skin tones. We want to make sure that we're noting skin moisture. Is the skin really oily? Is it really macerated? Do they sweat a lot? Is it in an area that's very wet all the time? And then on the flip side, or the other end of the spectrum, making sure that we're looking for if there's too much dryness. Is the skin too dry? Is it cracking? Are we running into problems with that? We want to check the skin turgor. So to see if the patient's too dehydrated, does the skin tent? Or on the opposite end, is the skin very edematous? Because that can put them at a higher risk for developing a pressure injury also. And then looking at skin integrity and making sure that we're documenting any rashes or lesions that are present, any skin thickening or calluses, any cracking that can be signs of high friction. We know in the feet, especially in our diabetic patients, if they come and they have a callus on their foot, we know that that area is a high area of friction. When we look at the classification system, so when you're documenting pressure injuries, the most common one that's used is a staging system. This was developed by the National Pressure Ulcer Advisory Panel, is where this classification system came from. So this is just saying that the stage 1 pressure injury, that's where our skin is intact. It might have that red, non-blanchable area that's lasting for more than an hour following pressure relief. So it's important before you're documenting this, though, to make sure that you're not just removing something and then immediately saying it's a stage 1 pressure injury. We need to give it that hour to demarcate. And if you're not seeing that erythema after an hour, then it's not a stage 1. If you are still seeing it and it's not blanching, that is the stage 1. A stage 2 is a blister formation or dermal breakdown. Sometimes people will get confused between, is it a stage 1 if it's clear fluid, or what if I have a blood-filled blister? So blood-filled blisters are considered a deeper loss. So those are usually considered a stage 3 at least. We want to make sure that when we are documenting this, that we're staging these correctly. We want to make sure that we're able to see the entire base of the pressure injury or of the wound. And the reason for that is because you might have an area that you might think is a stage 3. It's got full thickness tissue loss, but you might have a very sloughy base. And in reality, if all of that was debrided off, it would be a stage 4 pressure injury. Stage 4, those are the ones where it's full thickness tissue loss. There can be exposed bone, tendon, or even joint involvement. So if you do have a pressure injury that has a lot of slough in it, you can't see the true base, those are considered unstageable. When we talk about deep tissue injury, a lot of times people will think of this as, is it a bruise or is it actually a deep tissue injury? So the easiest to do when you're looking at this is look where it's at. Is it over a moni prominence? It can look like a bruise. It can have that purple or maroon discoloration to it. So making sure that we're really distinguishing that if it is over in area of high friction and shear and the patient is immobile, that it is more likely deep tissue injury versus ecchymosis or a bruise. So when we look at differential diagnosis, is it a pressure injury or is it something else? So like I said before, bruises are ones that are commonly misdiagnosed or sometimes missed. So people will say that it's a bruise when it's actually a deep tissue injury and vice versa. You can have incontinence-associated dermatitis. This is where it gets a little tricky because sometimes you can have kind of a combination of the two. So if you have a patient that has really bad incontinence, they get that really bad skin breakdown or incontinence dermatitis, but they're immobile, you can get the development of a pressure injury within that incontinence dermatitis because that skin is already compromised. So they're already at a higher risk of developing a pressure injury. Oftentimes, this is very common in our hospitalized patients that are incontinent and that are immobile. Other things that it could be intertrigo. That is in the picture in the middle on the left. You can see where it is just kind of a slit, a linear slit underneath an area of high moisture. Other things, you can have skin tears that can be misdiagnosed as pressure injuries. And then you could have blistering or edema. You want to make sure that if you see blistering or edema, like in the bottom picture, that it's not over areas of pressure or friction. This is a fracture blister. So if the patient has a broken bone in the area, sometimes you can get these. You want to make sure that it's not herpes simplex. Sometimes this can present very similar to a pressure injury also. Other things that are possible are COVID-19 lesions, and then also peripheral vascular disease if you're looking at something that is on the foot. So we need to remember that we're doing a complete assessment. Is this pressure injury or is it not pressure injury? And then if it's not, what is it? So when we talk about risk assessment, when we're actually looking at the patient and trying to decide how high of risk they are, one validated tool that you can use is the Braden scale. So the Braden scale is a tool that focuses on the categories of sensory perception, moisture, activity, mobility, nutrition, and friction and shearing. One key thing to remember, though, if you are using the Braden scale, is that because it's broken down into these categories, you can have a patient that's low in a category for, say, activity, but they score okay in the other categories of nutrition, friction, shear. So they might not be showing up as high of a risk, but we know, because we know our patient and we've done a thorough assessment, that even though they're a little higher in other categories, they're still at high risk for the development of a pressure injury. So we need to implement those effective strategies to prevent it. Things we want to look at are age of our patient. Are they very old or are they very young? Because both of those patients can be at high risk for the development of a pressure injury. What do they have for chronic diseases? What are their underlying diagnosis? Does the patient have diabetes? Do they have congestive heart failure? Are they limited mobility? Do they have a spinal cord injury? And if they do, at what level is that injury? And then we want to make sure, are they incontinent of urine or a fecal? And then if they are, how do we prevent that or how do we manage that so that they won't be at a higher risk for the development of a pressure injury? We want to identify hemodynamic thresholds for medical unpreventability. So this is a very hot topic right now, looking at what is preventable and what is not preventable in our patients. So we know that you can have a patient come in and they're in the ICU. They might be on several different vasopressors. They're very, very sick. We know that these patients are at high risk for the development of pressure injury. We also know that they're at high risk for the development of something called skin failure. So there's a lot of studies right now looking at Is it skin failure? Because we do think of the skin as a body system or an organ itself. And when we talk about organ failure, skin failure is organ failure. So I do think we're going to see a lot more continued focus on this topic in the future. The thing that I always tell our wound nurses and people that don't really know, I always say just make sure you're documenting everything. Document what you see, document what the patient is on, and that their risk is high for the development of skin failure and for pressure injuries. You're at a really high risk, our patients are, if they, for the development of stage 4 pressure injuries or deep tissue injuries, if, like I said, they have that low mean arterial pressure, so they might be on a lot of vasopressors to keep their blood pressure up. Their cardiac output might be low. They might have low albumin. They could have vascular disease. They could have a fever or extreme sweating. We know that sometimes our patients, especially those with spinal cord injuries, can have something called autonomic dysreflexia, which can cause them to be very sweaty if they have any type of movement or shearing, or sometimes even changes in temperature can cause that autonomic dysreflexia to activate and they might just start sweating. So making sure that we're noting that. Our patients can have decreased oxygen capability. We have our patients that have COPD that might not be having as great oxygenation or perfusion, which will put them at a higher risk for the development of pressure injuries also. So when I talked about the subscales of Braden score, so this is usually more important. We want to look at the subscale scores versus the overall total score when we are looking at how high a risk they are. So each category is scored on a scale of 1 to 4, except for friction and shear. That is scored on a 1 to 3 scale. So when we look at overall risk scores, so we have a patient that is a 19 to 23. Those are no risk. We have 15 to 18 equals mild risk, 10 to 12 equals high risk, and less than 9 equals severe risk. But like I said, with this overall score, we need to take into consideration the patient themselves and our assessment. Because you can have a patient who is a quadriplegic, but they might score a 17, 18 on the overall score. But we know that they're at higher risk for the development of a pressure injury due to their neurological status. So I look at developing a nursing care plan for our patients that are at high risk for pressure injuries. We want to focus that around positioning mobility, our surface support, skin and moisture management, nutrition hydration, our friction and shear reduction. We want to use things such as guidelines. There are lots of guidelines out there, the National Pressure Injury Prevention Panels, they all have their own guidelines. We want to look at flexible deadlines, so meaning that we are reassessing our patients frequently, that we're not rigid. So we don't say they're going to be improvement in their pressure injury by in 2 days. We need to keep that open-ended, not being so rigid or so stuck in our deadlines. And then we need to use our discretionary judgment too, meaning that we're changing our care plan based on changes of the patient, based on changes in the wound or pressure injury also. When we talk about positioning and mobility, guidelines out there recommend pre-positioning every 1 to 2 hours when the patient's in bed. We even want to perform some micro turns, they're called, or micro shifts when the in between the 1 to 2 hours. These are just tiny, you might just pull them to the side if they're not able to reposition themselves at all. And then one recommendation is when they're in the sideline or lateral position, you want to offload the sacrum, so they need to be at about 30 degrees. We want to limit chair sitting to about an hour if our patient is completely immobile. Use lots of pillows, foam wedges to help offload those bony prominences. We want to make sure that our heels are floated off the bed at all times. This can be obtained by either using a boot, like a heel protector boot, or utilizing pillows also. When we are utilizing things such as boots or offloading boots, we want to make sure that we are also putting pillows behind the patient's knees so that you're not putting a bunch of pressure on their knee joints. So you're not hyperextending that knee because the boots are too high. When we look at support surfaces available, a couple of things you can remember is we want to look at patient specific and use a high specification foam mattress or alternating air surface if our patients are at high risk for the development of a pressure injury. We want to ensure that pressure redistribution cushions are also used in their wheelchair or if they're sitting in a chair. So a lot of times when patients come into the hospital, this is where there can sometimes be a lack of communication. So we have a patient that's a paraplegic, and when they're at home, they have a pressure redistribution or a gel cushion in their wheelchair. However, when they come into the hospital, they don't have that. And say we want to get them up into the recliner or up into a chair to sit. Well, now they're not using a cushion. So we need to remember that these patients are very high risk for the development of pressure injury. We should be utilizing that offloading cushion anytime they are sitting in any form. So either if they're in a recliner or if they're sitting on another chair, that we are remembering that and we're taking that in consideration. We also want to utilize other things such as prophylactic silicone foam dressings to areas that are really exposed to high friction and shear as well as pressure. The prophylactic silicone dressings, lots of places are utilizing this. It actually doesn't do a whole lot for pressure redistribution. It helps more like with the friction and the shearing, especially at our risk individuals that are at high risk. So when we think about this, you can think about patients in bed, especially in the hospital setting. You can go in there, they have to have their head elevated at a certain degree for their breathing, but they're sliding down in the bed. So these patients are at high risk. You walk into the room and you see the patient and they're slid down in the bed, they're slumped over. So making sure that we're doing a good, proper positioning of the patient, utilizing these prophylactic dressings for patients like that. So if they're sliding down in the bed. And remember that even if these patients are somewhat mobile when they're at home, when they're in the hospital, they're really sick, they might not be able to reposition themselves as well. So making sure that we're assessing that also. So another thing when we talk about prophylactic foam dressings, we know there's a lot of different ones out there on the market. The problem with prophylactic foam dressings is, you might not have one that doesn't wear as long as you'd like. You might not be able to lift it up and assess and put it back. It might roll at the edges. It can cause too much drainage or peri-wound skin maceration. They can be difficult to apply, especially in challenging anatomical locations. So we all know that most of our patients don't have a butt that looks like the models that they bring in. Most of our patients are they're anatomically a little bit more difficult. So when we're looking for an ideal prophylactic dressing, we want one that's going to help maintain that microclimate. So what you're going to do is you're going to want to look on the package and look at what the moisture vapor transfer rate is. Most of the foams now on the market are really good. They're all about equal. We want to look at ease of application and then the correct sizes for the locations that we're using. So this is an example of utilizing a prophylactic dressing over bony prominences on the foot. And you can see in the top what happened. This is a patient that had a multi-layer compression wrap applied, and they developed pressure injuries. She has deep tissue injury over the malleolus and the side of her foot, as well as the tibial ridge. These are areas that oftentimes we have to remember are high risk for pressure injury development in our patients that have multi-layer compression wraps on. So the bottom pictures, these are just examples of places that preventive foam can be used. So when we talk about skin and moisture management, and you're going to see this again a little bit later on in the slide presentation, but we talk about it's important to know the pH of the skin and the scale. So we know patients that do not have balanced pH. We know in wounds are often a little bit more on the acidic side, or some are on the alkalinic side. So making sure that we're balancing that pH, the pH of the skin, so that it doesn't cause them to break down. We have our patients, if they're a little bit more on the alkalinic side, they will have that dryness. They could be very sensitive. They could be red, inflammation. If it's more on the acidic side, you're going to have those patients that have that oily redness. There can be inflammation also there. So how do we manage that, or how do we maintain that? We want to make sure that we're using pH balanced cleansers, fragrance-free moisturizers. We know our patients love those lotions and potions that smell good. Unfortunately, those that have a lot of scents in them oftentimes also have a lot of alcohol content in them, so they can actually dry the skin out more, which then puts our patients at even higher risk for the development of a pressure injury. We want to make sure that we are assessing or looking at and addressing their nutrition and hydration. So if they are in the hospital, or even if they're at home, can initiate a formal referral to a dietitian, and they can do a comprehensive nutritional assessment on the patient. We want to make sure that our patients that are at high risk, or if they have already developed a pressure injury, that they are receiving a high protein diet, or a high calorie shakes and snacks between meals. We want to make sure that we're monitoring their daily fluid intake to ensure hydration. We know that patients that are dehydrated have really dry skin, and this can cause them to be at a higher risk for the development of pressure injuries, or for skin breakdown due to friction and shearing. When we talk about friction shearing, so this is a good example of a patient that had a lot of friction and shearing. So he was a quadriplegic who utilized a sliding board for all of his transfers. So when he came in, he had all of this shearing next to it. So you can see that how the skin almost has that striated look to it. That is because he was just sliding back and forth, causing the injury. So ways that we can prevent that shearing is making sure that the head of the bed is below 30 degrees, and that we're elevating the foot rest also on the bed, so that knee hitch is up. We want to make sure that they're not sliding. We want to make sure that when we're transferring them, or when we're moving them up in the bed, that we're using a lift sheet. We're lifting, not dragging. We want to make sure that there's no wrinkles in the linen or the bed sheets. We also want to make sure that there's no bed trash. So bed trash is a big thing, especially in the hospital settings. A lot of times we will see that includes everything from needle caps to the patient's own garbage that they've created, making sure that's not in the bed. There's no plastic, no anything in there. I've seen all kinds of things. I've seen like the little caps that go on the end of or like the tubes, like the IVs that the patients have laid on and developed pressure injuries from. So making sure that there's no trash in the bed is very important. When we talk about pressure injuries related to medical devices, nearly 70% of those are associated with respiratory devices. So whether that is a BiPAP, a CPAP, or oxygen tubing itself, sometimes you can get it from tracheostomies also. Nasal cannulas, though, are the most common causes of injury to the nasal bridge, behind the nose, the nostrils. You can see in the picture, this is a patient who developed a pressure injury to her nose from a oxygen mask. The bottom you can see is a patient who developed a pressure injury to her posterior neck because the trach ties were too tight on her. Other areas that can develop pressure injuries, IV lines, arterial catheters. when we're looking at urinary devices, are the patients laying on the tubes, and making sure that they're free from that. Other things, pulse oximetry probes, cervical collars, basically anything that goes on the patient can cause a pressure injury. These are other examples of patients who develop pressure injuries from stuff. You could see ACE wraps. Like I said previously, multi-layer compression wraps can cause pressure injuries. The one on the top, this patient, he was laying in a foam donut cushion. And this is a good example of why we don't recommend utilizing foam donut cushions, because what ends up happening is where that area in the center is cut out, it's causing actually more pressure there because the blood is pooling in that cutout area. You can see the one on the bottom was a pretty significant pressure injury related to a C-collar. So this patient was discharged home without clear instructions on how to wash or what he was supposed to do with his C-collar. So he had his C-collar on for over a month and had not done anything with his skin. He had not done anything with the collar and then he came back. So now we'll look at debunking a couple of myths related to pressure injuries. So evidence-based guidelines, they kind of emphasize that different things, and there's a couple of misconceptions that still exist regarding pressure injury prevention, including the belief that these pressure injuries only happen in nursing facilities. There's that every 2-hour rule is mandatory. Like I said previously about the donut cushions. All pressure injuries are preventable or never events. Specialized equipment replaces manual care. And injuries progress linearly. So a pressure injury. So these are all myths that are out there that you might hear. So where do pressure injuries occur? We know that pressure injuries can occur anywhere. So they can occur in the patient's home. They can occur at a skilled nursing facility. They can occur at a group home. They can occur in the hospital. So it's important that we educate our staff if they are in a facility, and then we educate the patients and family members as well. So if the patient's at home, making sure that they know how to prevent pressure injuries, or how to care for any pressure injuries that the patient may already have. When we look at the myth of the every 2-hour rule. So recently there was a large NIH-sponsored trial that compared the repositioning of 2, 3, and 4 hours in nursing home patients. So these nursing home patients, even the ones that were high risk, it was found that there was really no difference in ulcer rate development based on the turning frequency. When the patient had, this is the key though, when they had a high quality foam mattress. So with that being said though, even though if they have that high foam mattress, they still have all the other things in place. This isn't saying that you should let your patient lay there for 4 hours. We know that each individual patient still needs an individualized care plan. So a lot of places still use that 1 to 2 hour guideline, but just noting that if you do go over a little bit or if you go over under a little bit, then it's important to make sure that we're tailoring that to our patient specific. When we look at chair cushions, like I talked about donuts earlier, that those increase the pressure where the ring is. So we try to avoid those. What you want is egg crate cushion, or those egg crate cushions and pillows, they can decompress really fast. So it might be providing a lot of relief right away, but after the patient's been up on it for a while, they will compress and no longer provide that offloading. Your best options that are out there are in interconnected air cells, or those gel high resilient foam combinations. So when we look at that preventability debate, so like I talked about previously, that there's a lot of research in this. Do we look at systemic failure versus clinical reality? So if we're just looking at the guidelines, they're saying, everything is preventable. Why aren't you doing a better job? When in our reality, our clinical reality, we know that these patients are under extreme physiological conditions. They are very sick. They might be on a lot of medications. They can have an ischemic event. And this, like I said, might just be organ failure. So looking at failure and then also looking at end of life failure. So is this an end of life skin change that we are seeing? When we talk about clinical decision making, we want to look at product application, advanced dressings, and then preventive devices that are out there. We know that pressure injuries can progress, but they don't always progress. By the time the discoloration appears, tissue underneath of it may already be infarcted and may be beyond rescue. These don't progress through numbers, so you're not going to have a stage 1 that goes to a stage 2 that goes to a stage 3 right away. We know that that might not be true. We know that they might evolve but not progress. So the injury in the beginning, it was actually a stage 4 pressure injury. You might have a stage 4 pressure injury that looks like a deep tissue injury, but now it's a stage 4 pressure injury. So they can evolve but not progress. So when we look at treatment for pressure injuries, if you have a stage 1 pressure injury, so this is just that non-blanchable red skin, the key to this is immediate pressure relief. Make sure that you're removing the pressure if it's caused by a device and making sure that you're protecting that area. So you can use a transparent film or silicone dressing to prevent that friction or shearing also. We want to make sure that we're not massaging the area because that tissue is already damaged. Massaging it can actually cause those capillaries to break and can worsen the pressure injury. When we look at stage 2, this is a partial thickness. So there is loss of the epidermis. You usually have exposed dermis, which is pink. It might be shallow, a clear fluid-filled blister. The biggest thing with this is, remove that pressure immediately. Good wound hygiene. Make sure that we are using that principle of a moist wound healing environment. For stage 3s, these are full thickness tissue loss. There could be subcutaneous fat visible within the wound. For this, it goes back to once again, immediately removing the pressure to that area, protecting the peri-wound skin, and then utilizing appropriate dressings to maintain a moist wound healing environment. Stage 4s is kind of the same. The thing with stage 4s, they might be deeper, have exposed bone or tendon. These oftentimes require surgical intervention for debridement. Not always, but sometimes you can use advanced dressings such as negative pressure wound therapy. You want to make sure that you are watching for infection, that you're controlling infection in these also. Deep tissue injury, this is often at the bone or muscle interface and progresses outward. So the tissue damage is inside out. They are often that maroon or purple color. It can feel boggy or like mushy when you push on it. It might be firm. Usually there's a thing called a 48-hour window. So the injury occurs 48 hours before we see any visual change. When we talk about pressure injuries that occur on mucous membranes, we don't utilize a traditional staging system, so they're not a stage 1, stage 2, stage 3. What we want to do is document them based on tissue loss. So these are going to be full thickness tissue loss, superficial tissue loss. We want to make sure that when we're looking at them, that the characteristics of non-blanchable erythema is not going to be visible. They're going to look like that yellow coagulum formation. This isn't necessarily slough. This is just a pseudo slough is what it's called. When we talk about advanced treatments, the main thing that we want to focus on is wound bed preparation. So looking at wound hygiene, making sure that we're cleaning them very good. We want to look at debridement. There's a couple of other things on the market right now. Negative pressure wound therapy with installation is one. We want to look at peri-wound skin protection. A couple of things that are out there. There's the CWON Advanced No Sting Barrier Film also, and then the Dermatac Drape, which if you've never seen any of these things, I'm going to show them a little bit later in the presentation. So back to why pH matters. So pH is important because for infection control, we know that most human pathogens such as Staphylococcus aureus grows best in a neutral to alkalinic environment. So that's where your pH is about 7 to 7.5. Acidifying a wound bed creates a hostile environment that inhibits the bacterial growth and biofilm formation. So that's why when we have a wound that's a little bit more on that alkalinic side, especially diabetic wound, people that have diabetes, making sure that we're utilizing something to create that a little bit more acidic environment. We want to look at enzymatic regulation, and healing requires a balance of enzymes called proteases or MMPs. And MMPs, they clear away dead tissue. In our chronic or hard to heal wounds, these enzymes are often overactive because of that alkalinic environment, which leads to destroying healthy and new tissue instead of the dead or dying tissue. So reducing the pH slows these destructive enzymes and helps the wound transition from our inflammation into repair. We also want to look at oxygen delivery. So according to something called the Bohr effect, is where hemoglobin releases oxygen into a more acidic condition. So a decrease in pH, even by 0.6 units, can nearly double the available oxygen at the wound site, which is essential for cell growth and collagen synthesis. And I say, well, why is this important? So this is important to know, especially for our patients that have like COPD or might not have the greatest oxygenation. Remembering that if the wound isn't getting as much oxygen to it, and the wound is really alkalinic, it's even getting less oxygen to it. So when we talk about wound hygiene, we want to make sure that we are doing a good job of cleaning. When we're cleansing the skin, even if they don't have a wound, we're making sure that we're drying it well. We want to make sure that when we're washing, if the patient does have a pressure injury already there, that we're not only cleansing the wound itself, but we're also cleansing the peri-wound skin and the area around that. When we talk about debridement, we want to look at non-viable tissue, making sure that we're removing that. We know that there's different forms of debridement. There's mechanical debridement, where you're utilizing a gauze or something to wash or scrub off the non-viable tissue. There's enzymatic debridement. This is things such as santal. Honey is another one that utilizes the concept of enzymatic debridement. There's sharp debridement. We're actually taking a curette or a scalpel and removing the dead or non-viable tissue. Autolytic debridement is utilizing the body's own enzymes to break up or remove dead tissue. This can often be achieved through use of an occlusive dressing. Biological debridement isn't used that much anymore. This is your maggot therapy that's out there. We want to make sure when we are debriding a wound that we're removing that peri-wound callus also, especially if it's over an area that's a lot of friction and shearing and we get that buildup of peri-wound callus. We want to make sure we're removing that to allow for epithelialization from the wound edges. When we talk about treatment, negative pressure wound therapy with installation is one thing that's available on the market. This is available on your inpatient settings. It is used with the VAC Alta. What this is it helps facilitate debridement through mechanical debridement. So it cleanses the wounds. It has a dwell and an installation phase. So it works in phases. You generally set it for 3-hour cycles. And then there's like a dwell time of 10 minutes. So where the fluid sits, and then the negative pressure comes on and removes that fluid, as well as providing the benefits of negative pressure wound therapy. So different solutions that you can utilize through the Veriflow therapy is saline is the most commonly used one because it's readily available for everybody. It does work very well, almost as good as all the other cleansers. It can be a good choice for clinicians who are new to the therapy also. Other wound solutions that are approved for it, there is acetic acid. That's one I commonly use. Hypochlorous acid, I commonly use that. Prontistan can be used through it, but you know, there's lots of studies out there. There's lots of clinical guidelines and papers out there showing though that saline is just as effective. So this is an example of a utilization of Veriflow therapy on a patient who has a pressure injury. So he was a paraplegic who developed a stage 4 pressure injury to his hip. And you can see when he came in that on day 0, that there was a lot of fibrinous slough covering the wound bed. So we did utilize the Veriflow therapy. We did do 150 mils of hypochloric acid every 2 hours with a dwell time of 10 minutes. The thing that's nice with the Veriflow therapy is that you can decide how much fluid you need in the wound, the cycles, or you can utilize something called Smart Instill, where the machine itself actually figures out how much fluid is instilled, how much you need, and on that default of 3 hours. So you can see with this that it did clean up fairly quick. So by day 21, by day 30, it was pretty clean. So we did switch him over to regular traditional negative pressure wound therapy once the wound was clean. He also did discharge on a negative pressure wound therapy home. So you can utilize this therapy kind of as a stepping stone. So if you have a wound when they're in the hospital and it's very sloughy or very dirty, and then you can transition them to traditional negative pressure wound therapy when they go home. So we talk about peri-wound skin protection, a couple of things out there on the market that they have. There's the barrier wipes, there's spray, there's CWON Advanced. So what CWON Advanced is a cyanoacrylate product. This product's really nice because you can apply it if you need to every other day, or you can apply it. It can actually be in place up to 7 days. It creates a clear film that you can see through. There isn't that peeling or crusting or cracking that you'll sometimes see with different barriers. And you also don't have to remove it. So if you've ever utilized anything with zinc in it or some of those other lotion type barriers, sometimes, when you're removing that dried on zinc, it's actually stripping or doing more epidermal stripping, which can put the patient even at a higher risk for the development of a pressure injury. Things you can use picture framing methods if the patient's on a negative pressure wound therapy, or which you can see down here in the picture of the heel. We utilized a barrier ring around there to protect that area of the peri-wound skin. And then if you've never used the Dermatec drape, this is what it looks like. So what it is it's acrylic on the inside of our circles and silicone on the outside. This allows for easy removal and reposition. It takes about 20 minutes for it to cure. So you can remove it and put it back down for up to 20 minutes. So to other advanced therapies that are out there, this is Promogram Prisma. If you've never used this is a collagen-based product. So this is important, or it's nice to use, because when I talked about the pH and the MMPs, how they act, what Promogram Prisma does is they actually function as a sacrificial substrate, meaning those high MMPs attack the Prisma, and they allow the natural body's collagen to deposit and lay down. So kind of getting the wound out of that inflammatory state and into the remodeling phase. So it helps to lower that pH, so making the environment a little more acidic so the bacteria can't grow, so the MMP or protease activities are decreased as well. So this is the advanced 7-day wear dressing. If none of you have seen this before, what it's called is peel in place dressing. So peel in place dressing is utilized with negative pressure wound therapy. The nice thing about this, though, is it's an all-in-one system. It has a non-contact layer built into it. So this can be left in place up to 7 days. So if you have a patient that's coming from a long ways away to your clinic, you can put the dressing on. They can come back in 7 days and you can change it. It's indicated for wounds that are up to 6 centimeters in depth. It comes in 3 different sizes. There's a medium, a large, and a small. So this has been a real game changer for me. I luckily was one of the first people to utilize this dressing. So this is a case utilizing the peel in place. So because it has that non-contact layer on the back, you're not going to necessarily see that beefy red cobblestone granulation tissue. You're going to see a wound that is more, the edges are flatter, there's red granulation. You might see kind of a film on the top of it. That's okay. That's just like a release of albumin on there. So this is a patient. He was a 63-year-old male. He had a stage 3 pressure injury of his buttocks. He did have it surgically ablated prior to this. This is when I saw him. We decided to utilize the peel in place dressing. So the dressing that could be left on for 7 days because he was coming from home. He was coming from a long ways away. Where I'm at, the area is pretty um, rural. So our patients drive for 2 or 3 hours to their appointments. So you can see here on day 14, this is what it looked like. His dressing did stay in place for a week. On day 21, and then on day 28. So the nice thing about this, because of that non-contact layer and the built-in Dermatec drape around it, the patient's skin was able to stay protected, and the patient had very little pain with any of the dressing changes. So, and the wound healed fairly quickly. So the patient really appreciated the fact that he didn't have to have a wound vac dressing change every 2 days or every 3 days. He was able to go an entire week with this new system. So I think over the next year or so, you're going to see a lot more information coming out about the peel in place dressing, about how you can utilize it and integrate it into your practice for our patients that have pressure injuries and those patients that have other types of wounds. I have used it on all kinds of different types of wounds. It is indicated for all wounds that traditional negative pressure wound therapy is indicated for. The only thing that you have to remember with the peel in place is the depth of the wound, because it's an integrated all-in-one system, that it can't be any deeper than 6 centimeters. That's the only thing that's important to note with it. All right, so with that, now we will open it up for some questions.
Thank
Thank
you
you.
so much, Emily. That was fantastic. Some great cases, some really awesome images there too. And thank you for putting up this slide. For those who are online here and can see the screen share, do make sure you scan both of these QR codes. The one on the left is going to be a bit of a feedback survey. The right-hand side will be if you're interested in learning a bit more, or you want someone from Solventum to get in touch with you, whether it be about peel in place or something else, please do scan that one on the right, and we'll make sure to put those links in the post-webinar email too. All right, we got some great questions here, Emily. So let me see if I can kind of group them a little bit here. One person was mentioning too, what kind of suggestions might you give to people who are working at home care for preventing pressure injuries with limited resources? What are some tips and tricks you might be able to suggest to them?
Sure. So those patients, if they do have limited resources, making sure that we are assessing them, their diet, making sure they're eating good. When you're in home care, that's kind of one of the nice things. So you do get to go to their house, so you can assess their layout. Are they sleeping in a recliner, or are they sleeping in an actual bed? That's a big thing. When we're looking at their house, do they sit a lot? Do they spend most of their day sitting in the recliner? Do they sit on um, chairs at their table that are wooden? Making sure we're doing an assessment of that. Things that are available, resources otherwise, if the patients could get access to um, a bed overlay. You can actually, I do sometimes have patients buy air overlays off of Amazon. You can usually get an air overlay, especially the cushions, for about $40.
Mm.
You can get air overlays for beds for about $100. So sometimes patients who maybe don't have insurance or don't have access to these, this can be an option for them to just order their own off of Amazon. Other things we do, we're lucky enough to have a uh, place organization here in Fargo called Hero, which is a medical supply store for patients where things are donated. So if, say, somebody had a Rojo cushion, but they no longer needed it, or maybe they got a new one, but the old one
Mm.
wasn't bad, they'll donate it there. So, checking if there's any available resources for of donation centers in your area is one. Other things you can do is just educating the patient and their family,
Mhm.
making sure that they understand, and getting the family involved too is really important. Because if the family is the only ones there during the day, they might have to help the patient reposition a little bit, showing them some tips. here's how you reposition, even micro shifts or lifting one area, sliding something under there. You can also get foam wedges. You can
Hmm.
buy different foams, even through stores. Like I do know I've had some patients that will buy foam, uh, like chunks of foam at hardware stores. That
Oh,
works.
interesting. I've haven't heard of that approach before, but I think
Yeah.
that's a good solution too. I know Jen in the chat was saying also most provinces here in Canada also have Red Cross equipment loan
Oh.
program. That's great to share there, Jen. And
Mhm.
one thing I'll do, I'll just mention too. I mentioned the Canadian Pressure Injury Advisory Panel at the beginning here. There are some resources province to provinces on the CPIAP.com website. I'll just put that in there, just so you've got it in the chat, everyone. And then you were mentioning, again, talking about support services, about mattresses, things like this too here. We had a couple questions about that as well. Can you maybe just describe a little bit the difference between maybe a high specification foam versus an air mattress? Maybe your experience with those.
Yep, so there's different categories. So there's high density foam. Those are more like your memory foam type mattresses. And then you could have an air. So an air mattress, which has different cells of air in them. And then you could have what's called an alternating air mattress. So alternating air mattresses are the higher level ones where you have a pump and it'll alternate or fill one of the chambers and then it'll fill the other chambers. So most hospital systems have alternating air mattresses. And then our highest one would be like an immersion bed. So, like your Clinitron beds or sand beds is another term for that. Those are generally just used in the hospital setting, though. And the reason for that is because they weigh so much. Most people's home foundations can't support the weight of those beds. So, unless you have a concrete foundation or a concrete floor, a lot of times those beds can't be utilized in the home setting.
Fair enough. And on note, you mentioned the Rojo cushion before. Someone in the chat saying they saw a tilt wheelchair and Rojo cushion at Value Village yesterday. Fantastic. And we had a question about the tilting there. One person
Mhm.
was saying, can tilt or pressure relief features replace the strict sitting time limits? Or what's your approach to that for pressure injury
Yep.
prevention?
So our patients that are wheelchair bound, we do, a lot of times try to get them chairs that have tilt abilities, um, so that micro shifts or tilting can replace some of the, strict hour in the wheelchair. So we'll just say, you could be in your wheelchair longer, but you need to be doing these micro shifts. So every hour, tilt back. If they have a pressure injury already, that might change. So if they have a stage 4 pressure injury, say on their sacrum or their coccyx, we might say, absolutely no sitting right now, because we need this to heal. We need it to not get worse. So I think a lot of that is individualized to the patient also. But, we have people who are quadriplegics, paraplegics, who are still working. They're out there. There's no possible way for them to lay down every 2 hours or every hour. So in that case, we usually say, even if you can just do a micro shift, if you can lift yourself up and pre-position if you're paraplegic and have arm strength, that's going to make a big difference. So trying to have them do that in conjunction with their advanced cushion every couple of hours, making sure that they are making a micro shift even every hour.
Thank you for touching on that. I know we had a couple questions about that, so that's great. I know we're getting close to the hour, so just reminding for anyone who does have to go leave the webinar here, it is being recorded today. You'll be able to access that within the next day or two on our website. So we'll definitely send you that information for it if you do have to head out. But thank you for joining us if you have to head out. We'll see if we can get to a couple more questions here. Some people are asking about whether, here it is. Should negative pressure, or when should negative pressure wound therapy be used instead of the standard dressings in the case of pressure injuries? I know you gave some great cases towards the end there, but did you want to maybe just reiterate what your signs would be to do one versus the other?
Sure. So, to be honest with you, if it depends on the wound itself and the patient. So, if the patient, doesn't have access or won't be able to come back or things like that, we just know logistically they wouldn't be able to handle negative pressure wound therapy. We won't use it. If we know that they, can't handle changing a dressing, every single day, we might go to negative pressure wound therapy. The great thing with the new peel in place is that you can utilize that on wounds you maybe wouldn't have before because it can stay in place for that 7 days. So the patient's going to be coming back once a week versus every couple of days. Um, uh, Other than that, it just goes with the standard. If you're not utilizing the negative pressure with installation in the hospital, if the wound is clean, so 70% granulation, there's not a lot of slough in it, you can utilize negative pressure wound therapy on most wounds. It's just kind of those indicate contraindications would be like exposed vessels, wounds that have malignancy in them. Those kinds of things.
Perfect. And maybe a couple questions here just on the assessment piece or the early identification piece. One person was asking about just a clarification of the earliest signs of deep tissue injuries, and someone separately was asking how we maybe the signs of differentiating MASD from pressure injuries. If there's just a couple tips you can maybe give on both the
Yeah,
DTIs and the MASD.
yep. So when you have a patient that has that moisture associated skin damage already, that puts them at a really high risk for the development of a pressure injury. So the thing you have to look at when you're looking at that is the pressure injury developing over a bony prominence? So a lot of times with MSAD, you'll see it on bilateral butt cheeks or you'll see it on just one versus the pressure injury that's actually over the bony prominence. So where is the interface of that bone to skin? Because that's where it's going to develop. Unfortunately, we see that all the time with the patients. They'll have really bad MSD, and then they'll develop a pressure injury over the coccyx or even on the sacrum because they're sitting and the skin is already broken down. So making sure when we're assessing that we're doing a good assessment. It's very important for these patients that do have moisture-associated skin dermatitis that we're treating that right away appropriately. So really removing that causative. So either if they're incontinent of urine or incontinent of feces, making sure that we're looking at ways to fix that underlying problem. Do they need a catheter for a while? Would that be appropriate to get the skin to heal? Because we know already skin damage puts them at a really high risk for developing a pressure injury. Making sure that we're treating that appropriately to utilizing things like Avalon Advance, utilizing things like antifungal if there's a fungal component to this. Make sure that we're treating that underlying problem also.
Yeah, I think that's a great answer. And again, treating that cause being a very important
Yeah.
piece there. And then again, one more point then too on deep tissue injuries.
Mhm.
How are we assessing for deep tissue injuries typically?
Yep. So deep tissue injury, what you're going to look for, like I said, is it almost looks like a bruise a lot of times. It'll present as. So making sure that we know kind of if it's over that bony prominence, the patient never had a fall, they never had anything like that, but it's looks like a bruise. It's over a bony prominence or area that has a lot of friction or a lot of pressure to it. It's going to kind of have that purpley hue to it. It's very important, though, to note too that sometimes especially patients that have a darker skin tone, that we might not be able to assess that right away. It might be a lot of damage done already. So looking at trying to get that on the preventative side before that occurs, that injury occurs, is very important. Other things, it can look like a blood blister almost. It'll look like a bruise that's really soggy or like boggy when you push on it. Other things that you need to differentiate between, is it a hematoma or is it a pressure injury or deep tissue injury? The key thing there is good assessment and asking the patient, did you fall? Did you hit it on something?
Right.
If this just developed out of the blue and it's over a bony prominence, we know the patient was laying for an extended period of time. We know that it's more likely a deep tissue injury.
Yeah, well, thank you for touching on that. And I know we're a few minutes over here, so appreciate all those who are able to stay on with us. And of course, to yourself, Emily. I'll maybe just do one more call to action for everyone before we head off. Again, we thanks Solventum for making today's webinar possible. And we are so delighted to have Solventum as a platinum sponsor at our joint congress with the World Council of Enterostomal Therapists. That's coming in just a month from yesterday, pretty much. If you're already registered, make sure to check out Solventum at our Congress. They'll be there in our exhibit hall. They'll have a very big, prominent spot there, so you won't be able to miss them. But do check it out if you're not already registered. There's going to be lots of great education. We're going to be talking quite a bit about pressure injuries there as well too. So I just wanted to put that there. Emily, thank you so much for coming on with us today. I know we couldn't get to every single question, but from the chat, we're seeing so many thank yous, so many messages of appreciation here. So we appreciate you sharing your expertise, and we hope to see you again, whether it's in Canada, maybe it's at a conference in the States, but either way, we hope to keep in touch and see you at another webinar or educational event in the future. Alrighty. For everybody else, we're
Okay.
going to send over a email, as I said, in the next day or so with these links. Make sure to fill them out so you can get your certificates of attendance. We'll get the recording to you as well. And other than that, we hope you have a good rest of the workday. Thanks, everyone.